Okay, and just to go over the roles again, I'll be monitoring the chat, looking for any raised hands, any questions that come up, and kind of taking note of those. I can also, Liz, if you want, I can kind of go over some brief housekeeping items at the beginning, mentioning some of the options that the participants have as far as having access to some interpreters and some things like that.
Yeah, if you want to start us out with that would be good. I have the window open, but it's really minimized. I'm just looking off notes basically the whole time. So
sure.
Just FYI.
No problem. And at the end of the session, I'll be capturing some high-level takeaways. We're gonna capture 3 main takeaways, and those are gonna be shared with the rest of the participants in a separate session at the end of the day.
Okay.
All right. Great. I think I can see the attendee list increasing. Good morning, good afternoon, good evening, everyone. We're just going to wait a couple of minutes for everyone to join. Thank you again for joining us for this session on HTS and reaching the first 95. So we'll just give it one more minute. I see we already have about 45 attendees. And then we'll start off with some housekeeping items. Oh, got it. Thank you, Suzanne. Okay. Okay, I think we'll get started. Good morning, good afternoon, good evening, everyone. My name is Mike Sayre, and I'd like to welcome you to our session today on HTS and reaching the first 95 as part of the 2nd annual PEPFAR local partner meeting. Before moving on, I wanted to just quickly cover a couple of housekeeping items. I'd like to ask all of you to please mute your microphones when not speaking. Throughout the presentation, we will be collecting your written questions through the chat feature. If you would like to ask a question, please feel free to type your question in your preferred language into the chat box on the right side of the screen. Finally, we are also going to have a poll at the end. So please, it's only 3 questions. Once we're finished, you can fill out that poll. We're also going to have a Q&A section where we're going to be reviewing the questions. And as I mentioned, we are going to be working off the questions that you write into the chat box throughout the presentations. And as a way of introduction for our participants, I'd like to ask that you type your name, organization, and the country where you're based into the chat box. That way we can know who's joined us, because we can see your names, but we understand that you as attendees may not be able to see everybody. So that would be really helpful. So please just write in your name, organization, and the country where you're currently based. Well, without further delay, I would like to invite Elizabeth Manfredini for introductions. Thank you.
Great, thanks, Mike. Good morning, good afternoon, and good evening to everyone. We're excited to have you on for the HTS and Reaching the First 90 session of the 2nd annual Local Partners Meeting. I'm Liz Manfredini, one of the senior HTS advisors on the OHA HTS team and the moderator of this session. Also with me is Michael Sayre, one of our local partner transition advisors at OHA, who has done the heavy lifting of coordinating this session. We'll be monitoring the chat for questions as well as Chelsea Douglas from the OHA HTS team, who will be helping administratively. Over the next hour, I'll be giving a brief presentation on USAID's global HTS implementation. We'll be hearing a presentation on HTS programming in Tanzania by Deloitte Consulting Limited, and then we'll have time for Q&A. For background, Deloitte Consulting Limited, together with its technical partners, Family Health International, and Gender Health and Management and Development for Health, has been implementing an integrated comprehensive health program known as USAID Boresha Afya Southern Zone in the 6 regions of southern Tanzania. It's a 5-year program with the purpose of increasing access to high quality, comprehensive, and integrated health services in communities, especially for women and youth in areas of HIV, TB, family planning, MCH, and malaria. The program has entered its 5th year of the implementation, supporting 618 facilities for the HIV program. It has shown a steady growth in HIV case identification from around 30,000 clients in its first year to around 40,000 clients in year 4. Our 2 panelists, which we are thrilled to have today, Dr. Marina and Dr. Beatrice, are joining us from this program. Dr. Marina Nelikela is the Chief of Party of USAID Boresha Afya Southern Zone program. In over 20 years of her career, she has served as the first female executive director of the Muhimbili National Hospital, which is the only national referral hospital in Tanzania with 1,500 beds. She's published over 50 publications in peer-reviewed journals, has attended various local and international forums, and serves as a member on several boards. Dr. Marina holds a Doctor of Medicine degree from the University of Dar es Salaam and a Master's of Public Health from the Muhimbili University of Health and Allied Sciences, and a PhD from Kyoto University, Japan. Also with us is Dr. Beatrice Christian is a medical doctor by profession with a Master's in Public Health from the University of Dar es Salaam and Muhimbili University of Health and Allied Sciences, respectively. She is currently working as the Senior Advisor, Technical and Operations for USAID Boresha Afya Southern Zone program since 2016 under the consortium member Management and Development for Health. Dr. Beatrice has over 13 years experience in HIV/AIDS prevention, care, and treatment programs, as well as TB, working in different capacities from a clinician in the HIV care and treatment clinic to her current position. Thank you both for joining. I'll open up briefly for all panelists to give a quick hello.
Good morning, everyone. I'm Mike Sayre. It's a pleasure to be on this panel, and I look forward to the discussion. And thank you for joining us.
Okay, Mike, if we can switch to the first presentation slides.
Great. Hi, Monica. We still can't see the presentation slide.
Great, thank you. Monica, next slide, please. Great. So Dr. Beatrice will be presenting for Deloitte. However, before we get to her presentation, I'll be starting us off with a presentation on USAID Q3 global implementation and achievement for HTS, as well as covering some of our strategies and approaches. Next slide. We know that some countries face challenges and impacts due to movement restrictions as a result of COVID-19 in the last few weeks of Q2. However, we were expecting to see the full impact of the SARS-CoV-2 pandemic in Q3, and you can see here that the number of newly found PLHIV decreased in nearly all countries, most likely due to COVID-19 service disruptions. Next slide. Despite the impacts of COVID-19 overall, we're at 78% for TST and 54% for TST pause. We have 20 OUs on or close to target, 3 OUs with overall underperformance in both HTS, TST, and TST pause, 7 OUs on track for testing, but underdiagnosing, and a few OUs who are clearly over-testing. In the case of Zambia, you can see that they are also overachieving on case identification, with Zambia being at 129% tested and 196% diagnosed. We also have 5 OUs who are achieving their HTS self-target. Next slide, please. For index testing, you can see that we are continuously increasing our percent of positives who are identified through index every quarter. The percent stayed steady in Q2, and we even had an increase in volume of positives identified, despite the index testing halt from OGAC that lasted from January 14th to March 24th and potentially impacted 46 of our IPs who implement index testing with key populations across 21 OUs. In Q3, we increased our percent pause from 21 to 25%, though our volume decreased, again, most likely due to COVID-19 impacts. Next slide. In COP19, the standard was to offer index services to identified PLHIV, which we have set to be all newly diagnosed. So we use the metric of TST pause. However, in COP20, this has changed to include not just all newly diagnosed, but also all virally unsuppressed individuals. You can see that we still have significant work to do to meet the standard and are moving forward to ensure all missions and IPs are aware of this change. Next slide. As we continue to scale offering of index testing services, we need to ensure that they are safe and ethical, that they meet the WHO 5 Cs, are completely voluntary, are client-centered, and that services are never withheld from clients and clients are never pressured into disclosing the names and contact information of their partners. Next slide. With disruptions to facility testing, USAID has continued to scale up self-testing as an approach to continue providing testing services during COVID-19, which is more important now than ever with the pandemic. We can see in the top visual that USAID distributed 266,000 test kits, more than doubling the number distributed the same time last year. Self-testing was also the only HTS modality to not see a decline in Q3. Next slide. This is showing the top 5 OUs from Q3 with the highest volume of HIV self-testing kits distributed. 4 of them, Malawi, Zimbabwe, Zambia, and Kenya, also correspond to OUs with our highest targets. You can see that our programs have continued to make progress with distribution from 2 years ago when we first introduced self-testing. We're currently only at 47% of our global targets in Q3. We still have a long way to go with self-testing, but are continuously seeing improvements, such as in Ethiopia, where policy issues have recently been resolved, and the Global Fund just ordered 500,000 kits, and Mozambique, which has previously not allowed self-testing, but has recognized its benefit with COVID-19 and physical distancing, and will now allow limited distribution. In FY20, our top 5 OUs only constituted 15.2% of our overall targets. So every OU and IP was critical in USAID being successful in achieving our HTS self global target. Next slide. Despite the positive steps that we are making, you can see that we still need large improvements in numerous OUs to be able to reach our HTS self targets. From this slide, only Ethiopia, Malawi, Eswatini, and Cameroon have met the 75% achievement expected at the end of Q3. Though Zimbabwe is almost there. When we look into how we're utilizing self-testing, we see that the majority of tests 58% are directly assisted distribution, with limited reporting on the optional disags for unassisted self-testing. We see that 47% have been distributed for use by sex partners, 40% have been distributed for self-use, and 12% were distributed for use by others, which can potentially be peers. In addition, FSWs were the most reported KP distribution, followed by MSM and people in prisons and other closed settings. Next slide. As we strive to increase the distribution and use of self-test kits, we need to ensure that we have a framework for a core minimum package that includes a self-test kit plan for procurement of commodities, programming components of distribution, a strategy for demand creation and reaching target populations, and an M&E plan for data collection and monitoring of outcomes and linkage to confirmatory testing when feasible. Next slide. Looking at linkage, most of our OUs are above 85% linkage. It's important to remember that linkage is a proxy in which we compare our TSD pause against our TX new, and that there are a lot of other inputs, influences, and nuances with this. For instance, Western Hemisphere is a very high percent, but it's really the treatment numbers in Panama leading to this percentage, not the whole region. Tanzania and Nigeria are leading the way at 96 and 101%, which is fantastic. And South Africa, which is our largest program, is at 92%. Asia Regional is at a low percent, but this is skewed because 3 countries in Central Asia, where we have a testing program, CDC has the treatment program, and Ukraine has the lowest percent, but again, that's because we predominantly have a testing program, which we link to the CDC treatment program, and only our program in the penal sector does treatment. Next slide. That was just a brief overview of our Q3 programming. Thank you again for joining the session. Our OHA HTS team is always ready and available to answer any questions and to offer support. You can reach us at htsteam@usaid.gov. And on the right here, you can see that we have individual HTS POCs who cover specific OUs. I'll now turn it over to Dr. Beatrice to give her presentation on Deloitte programming in Tanzania.
Okay, thank you. Good morning, good evening, good afternoon, everyone. Please, next slide. So I'll be presenting on behalf of USAID Boresha Afya Southern Zone, which is implemented by Deloitte together with its 3 technical partners, FHI 360, Management and Development for Health, and Gender Health. Next slide. And we'll be looking at our index testing experience, which to us is a promising approach towards reaching first 95. Next slide. So the outline of the presentation today will be looking at the program overview, the program coverage and thematic areas. Then we'll look at the HIV testing services across the supported regions. Then we'll look at the index testing approaches and its performance. And then we'll look at the lesson learned. Next slide. So as I've said, the USAID Boresha Afya Southern Zone is being managed by Deloitte, which is a prime organization together with the 3 consortium partners, but it's also implemented through the local government agencies, the supported health facilities, CSOs, CBOs, and FBOs. It's a 5 years project. Now we're in the 5th year of the implementation, and we are receiving fund not only from PEPFAR, but also special funding through maternal and child health, family planning and reproductive health, special funding for TB, as well as funds for malaria through PMI through the USAID. The vision and mission of the project, it's providing a dynamic and integrated platform for delivery of health services to ensure improved health status for all Tanzanians. Next slide. So as it has been mentioned, we're implementing in the 6 regions of the southern Tanzania. And these regions contribute close to 20% of all clients who are receiving HIV care and treatment services in the country. The program has 3 results areas. We are looking at improving enabling environment for health services provision, improving availability of quality and integrated health services at facility level, as well as increased access to health services at community level. This is an integrated comprehensive program. We're not only implementing HIV, we are also implementing TB, family planning, maternal and child health, and malaria. HIV and TB services are implemented in all the 6 regions, family planning in 5 regions, malaria in 4 regions, and maternal and child health in 1 region. And gender and youth is a cross-cutting strategy across all the thematic areas. Next slide. Going back to first 95, the HIV testing services, we are providing HIV testing services through 4 different modalities. We have optimized PATC, we have index testing, HIV testing in TB clinics, and also in antenatal clinics. The optimized PATC, we're using a standardized national HIV risk and symptom screening tool, and it's done at the OPD settings, as well as in the community settings through mobile testing for the key and vulnerable population, which also includes adolescent girls and young women. Index testing, it's implemented for both facility and community. Just to say, this is a facility and community-based HIV program, so we're implementing both facility testing modalities and community testing modalities. And for the index, we are covering the newly identified positive and the newly initiated clients on treatment, as well as clients with high viral load or clients with, who have been returned to care after being lost to follow-up. So we are doing elicitation to get the sexual contacts and biological children for conducting the index testing. For the TB, all the TB with unknown HIV status and all the pregnant women with unknown status are also provided with the HIV testing. So in a snapshot for performance for the just ended financial year up to Q3, you could see the program surpassed the expected quarterly achievement by end of Q3. The expectation is to be around maybe 75%, but for the HIV testing and post-case identification, we're at 91 and 95% respectively. And this also is being seen for the index testing, and as well as the positive cases identified through index testing. You could see across the quarters, we have been maintaining the performance throughout. Next slide. So our index testing approaches. The program is implementing index testing, as I've said, for both facility and community testing. For facility settings, we are supporting facility healthcare providers to conduct index testing either within the facility, at OPDs, at care and treatment points, at PMTCT or TB HIV points. And for contacts who require follow-up at their home settings, then the providers are supported to provide the index testing services outside the health facilities. But among the turning point for the index performance for this program is due to challenges of human resource. We had to embark on deployment of short-term testers, which are working parallel with the healthcare providers in the supported facilities and also in the community settings to conduct the index testing. These are the either retired healthcare providers or graduates from the clinical or nursing schools, who are yet to be employed by the government. They are given training on index testing, and then they are providing the services. All these providers who are conducting index testing have received the national curriculum for index testing, and they are following all the WHO 5C and conducting the IPV screening and the GBV screening. So the supported facilities for this modality is we are supporting 618 facilities. They are divided into tiers levels from tier 1 to tier 4. The tier 1s are the ones which are contributing a large number of patients, and our monitoring is done by following the 80-20 rule. So we have a system, we call it a backstopping approach, where project staff together with the local government authorities, the regional and council health management team, providing support to a certain council or to a certain number of supported facilities. They provide close monitoring across the index testing cascade, performance of the healthcare providers and the short-term testers. They provide on-site mentorship daily, as well as ensuring documentations in all the national reporting tools, as well as the program or donor required documentation tools. We are also using an approach of daily data monitoring, which helps in early identification of gaps, as well as formulation of mitigations measures immediately. And this mostly is done using the WhatsApp groups. So those backstops, the project staff who are serving as backstops in those respective councils, they have special WhatsApp groups, which involves the regional and council health management teams, the supported facilities, and they're sharing data daily. And also we have a one group for each region, where those different councils, they convene at that one regional WhatsApp group, and they share performance, and we identify gaps early, and the mitigation measures are being set in place. All these are done together with the local government authorities. Also, our technical support covers across the index testing cascade. We are looking at both elicitation rate. We expect they are being mentored to understand that we have to reach at least 80% elicitation ratio of 1/2 or 1/3, testing coverage of 90% and above, and yield of 20% and above. And we are working closely with the facility management team, as well as the regional and council health management teams. Next. Next, please. Next. Thank you. Sorry, go back one slide. Yeah. So after looking at our approach, before talking of what we have seen as approach, as a performance in the just ended financial year, we are also working with very closely with our supported CSOs, which harbor the community healthcare workers and volunteers. These are used to escort healthcare providers or the short-term testers, particularly for the contacts which require follow-up at their home settings. These are the ones who know those villages, and they usually escort these providers and short-term testers to those settings for conducting index testing. And also, we have said that our focus is among newly identified HIV positives or TX-new, but we usually work on a backlog of, we call it backlog of TX-new. Like we were in September, you don't only concentrate on newly identified POs for that month of September, but we also look at the missed opportunities in prior month, June, July, and further elicitation is being conducted to those index clients to ensure that we have adequate pool for conducting the index testing. So our performance for the up to June for just the ended financial year, as we have said, the index testing versus annual target, we were at 145%. And we could see across all the supported 6 regions, there has been a remarkable performance above 100%, but a special attention to a region called Ruvuma, where we started slow in Q1, and then we picked up in Q2 and Q3. And this was just a newly region given to the project at the start of the COP19. That's why you could see the performance was a little bit slow in Q1. We are seeing the same picture for the POS cases identified, index POS cases identified, where the overall performance is above 100% at 187%. Next. Next, please. Okay, yeah. So looking at the quality of the index testing, as we have said, we are looking along the whole index cascade. You could see here what we have presented, our yield, which has to be above 20% in all the regions. This is a snapshot of Q3 performance. We're above 20%, as well as the elicitation, the testing coverage was above 80 for almost all the region, with exception of one region. On average, we were at 85%. The elicitation ratio, though not indicated here, was 1/1.2. So we still have a long way to go to ensure we reach the target of 1/2. Next. So, index testing has been like the main identification modality for this program. You could see from this snapshot of our quarterly performance for the COP19, the lower part of the graph, the green ones, shows the facility index pores identified compared to the total pores identified in the respective quarters. So it's around above 55 to 65%. And you could see I'm sorry, I can't show with a pointer, but the community index had started with 6% in Q1 and then improved to 13, 16 and, by the end of Q3. Also, we had a slow start for the contribution from the community end because it was just a new component which was given at the start of COP19. But we have worked on our strategies, and now we are seeing it also contributes. So in average, the overall by end of Q3, the index pose contribution to the total positive was around 73%. But this has not been like merry throughout. We also have our struggles at the COP18. The index pose contribution was ranging between 8% in Q1, then to 38, Q2, 55%, Q3, and then in Q4, while we fine-tune our modalities, engagement of the short-term testers, and now we are seeing from Q4, the COP18, to date, we are ranging above 70%. Next. So the key lesson learned for us, deployment of short-term testers has been among the cornerstone improving case identification through index testing. Also, collaboration of short-term testers and facilities care workers is among a key area which brings success for the HIV case identification. You know, when you deploy them, you don't do the smooth engagement with the healthcare providers. They might feel that you've put people who are taking over their responsibilities. You need to have a smooth engagement, and then the success will be seen. Also, close monitoring by the project staff, both at the level of the regional up to the level of the HQ, is also among the cornerstone on improvement of performance. As we have shown, it addresses gaps on daily basis. Also, daily data monitoring across the index cascade is also among the key areas which, if you want the index testing to be successful, you have to invest on that, as well as, without underscoring, the role of the local government authorities through RSHMTs and facility management team in providing oversight is a key area to success. I think that is the end. Thank you.
Great. Thank you so much, Dr. Beatrice, for that excellent presentation on HTS implementation in the Bururatia-Afia Southern Zone program. Please enter any questions that you have on either presentation or any HTS questions in general into the chat or raise your hand. We're going to move now to the Q&A session, and I'll hand it over to Mike to facilitate that.
Great. Hello, everyone. We've gotten a couple of questions here through the chat box. This first question was asked by two of our participants, and the question is to Dr. Christian. What do you mean by the 80-20 rule? Can you clarify what you meant by that on your slide?
Oh, okay, thank you. So when we say we are following the 80-20 rule, we are looking at the pool of the supported facilities, and we arrange which ones have higher numbers of the clients on treatment. So the 20%, usually it's the 20% we contribute to the total, even if it's newly identified positive or clients initiated on treatment. So we are investing most of our support in those facilities which contribute 80% of the results. So our daily monitoring, our daily close follow-up, most of the resources are diverged towards those facilities which contribute 80% of the results. Thank you.
Great, thank you so much. Our next question is from Happiness Mkatswa. Many areas had targets overreached. Please explain how this was possible. Were targets set too low? I think this question is also for Dr. Beatrice Christian.
An interesting question. I think among the strategies we have shared, among the key factors which contributed to over-surpassing the targets as it has been shown. So working closely with the local government agencies, the regional council health management teams, our daily follow-up, daily monitoring of data and performance, our deployment of short-term testers, engaging the healthcare providers, providing the on-site mentorship, they all contribute in ensuring that we have that performance. Thank you. I hope I've answered.
Great, thank you. Dr. Christian, you're going to be receiving a few more. We have one from Jude Okedia. Any specific challenge on index testing for adolescent girls and young women? Have you faced any specific challenges?
Yes, we have said that we are conducting index testing at community settings, which covers also the KVP, including the adolescent girls and young women. Yeah, it's not an easy group, not easy to disclose information on their sexual contacts. It requires repeated follow-up. It requires the peer group's involvement, one-on-one discussion. So not only to the age you asked, the whole of index testing is not like a snapshot implementation. Like today you talk to a patient, you get everything you want, you get the information about the contacts and how to reach them. It's a long process which requires repeated follow-up, providing and reassuring them of confidentiality, observing all those, the 5 C's, and then you can get the results you want. So yes, we are still working with that group, particularly on ensuring that they are comfortable, they are seeing examples of their peers who maybe have disclosed their contacts, and nothing happened to them when the contacts are followed up for index testing. Thank you.
Great, thank you. Our next question is from Rachel Manyeki. Can you please speak more about the short-term testers? How and when do you engage them?
Yeah, so for short-term testers, as I have said, we understand in our third world countries, we usually have challenges of human resource. So initially when we were implementing index using only the healthcare providers, we learn a hard lesson that we cannot wait for the provider who will be working maybe from 8 in the morning until 4:30, and then has to go out and conduct index testing. We have to look of another supporting mechanism to support the index testing. That's when the idea of engagement of the short-term testers was brought about. So as I've said, these are retired some are retired medical professionals or graduates from the clinical nursing schools who are yet to be employed by the government. They are jobless. So we work with the regional and district medical officers offices and conduct recruitment processes. They undergo competence testing for the HIV testing. When they reach the required cutoff, then the process of engagement is done, orientation is done to them, and they are attached to different supported facilities. We look at the facilities which has maybe more challenges of human resource, or facilities which have potential of conducting more index testing. And then we attach and they work hand in hand with the healthcare providers. But their main responsibility or primary responsibility is index testing from morning till evening. They just go there looking at the list of TX new, the newly identified positive, and conducting index elicitation, following up contacts, and supporting the whole process of index testing. Thank you.
Great, thank you so much. Dr. Beatrice, your presentation has elicited a lot of interest. So this is very wonderful. We're glad to see the questions coming in. The next question is from David Mutinda. He would like to know, what is the experience that you have had in reaching men? Any specific approach, or did you take any specific approach in your implementation?
Okay, reaching men has been a challenge for the whole country, and for us, index testing is among the approach we are using in reaching men. We have other approaches like providing special testing points at the OPD settings. We call them male coders, engaging sensitization activities at community, and then they are referred at OPD at those special corners. But for us, index testing is among the key approach for reaching men, and we have seen some improvement in case identification through that. Though what we are seeing, it's easier for a female, newly identified newly identified man to disclose about the information of the sexual contacts compared to females disclosing about information about their male sexual contacts. So it's a challenge, but it has been one among the promising approach of reaching men. Thank you.
Great, thank you so much for your response. We have a question from Frederick Katunga Mwansa. What is the best time to do elicitation when talking to the first client? After the first session or at the end of the session? Do you have any thoughts on that, or any data experiences that you could share?
Sorry, I did not get it. First session or after the first session? I did not understand that part.
Sure. The question is, what is the best time to do elicitation when talking to the first client? After the first session or at the end of the session?
Okay, if I understood, it means you have a newly diagnosed client and maybe you're enrolling in CTC. Should you start with elicitation or you complete the other care and treatment enrollment processes and then you discuss about elicitation? I don't know if I have a direct answer to that. I would say it varies from client to client. So you have to assess how the client has accepted the HIV results. You could have to give him or her time to process that while you are doing your CTC enrollment, and then at the end you conduct the elicitation. But it varies from client to client. Thank you.
Great, thank you. The next question is from Baraka Ananya. Can you explain your tact upon reaching key population, particularly MSM?
Can I explain the what?
Your approach upon reaching key population, particularly MSM.
Okay, so for the part of the country we are serving, and for data we have, I don't think we have seen MSM. Most of our KVP group we are serving are the female sex workers and their partners, as well as the adolescent girls and young women. But I believe in the other parts of the country, they are seeing a number of MSM, but I cannot talk on how they approach that.
Thank you. The next question is from S. Galbad. Do you have specific strategies targeting adolescents in bringing partners for HIV screening?
I believe he or she is talking about the HIV positive adolescents. If that is the case, it has been an area of where we are not doing very well, and it's an area which we have to strengthen to ensure that the adolescents, we are also conducting index elicitation among adolescents. We know some of them have sexual debut at an early age. So at the moment, I think we don't have something maybe worth sharing because it's an area which we need to improve. Thank you.
Great, thank you. Our next question, we have time for two more questions and one from one of our panelists. So two more questions for participants. This next question is from Titus Koikoi. What is your experience with HIV counselors' abilities to handle the daily workload between provision of full index testing counseling versus dealing with regular patient flow outside of index testing and health facilities? Are you addressing this? And if so, how?
Okay, so for Tanzania, the government has been pushing for the index testing activities to be part and parcel of the care provision at the care and treatment centers and also at all the HIV testing points. So we have the backup of government, but we understand the shortage of human resource. And if we were operating without having deployment of additional those short-term testers, maybe we wouldn't have seen these kind of results. So I would say if the program has resources, should think of providing that additional support to the supported health facilities, particularly those with shortage of human resource, to ensure that the index cascade is being done at its full potential. Thank you.
Great, thank you. And our final question from the participants is from Cosmos Gamba. Could you please share best practices on conducting provider-assisted referral outside the health facility? How do you do it? How do you provide conducting provider assistance referral outside the health facility?
Okay, yeah. So as I've said, the index testing is being done at facility setting as well as at community settings, in the home settings of these index contacts, whether biological children or sexual partners. And the healthcare provider, as well as the deployed short-term testers, together with if they are escorted by the community healthcare worker, they're the ones who are responsible to ensure the newly identified positive from the index testing happening in the community reach the health facility. So we don't offer like transport reimbursement for those newly identified positive from index testing to reach the facilities. It's just that we continue with counseling and follow-up, and our linkage rate is fairly good through that approach, above 90%.
Great, thank you. Now I'd like to ask my colleague Vincent Wong, who has a question he's dying to ask. Please unmute. Yeah, there you go.
Hello, hello. Yeah, this is Vincent Wong from USAID Washington, the HTS cluster lead. Thank you, Dr. Beatrice, for a lovely presentation. Really, really strong results. I guess just a comment first, and that is just noting that Tanzania was really one of the countries at the forefront in implementing index testing, and actually in Njombe back in 2015, 2016, they were really kind of set the standard for how this should be implemented. It was great to see the results of your clinical testing and your community testing and the connections there, and the importance of sort of PITC and testing in other clinical settings as an engine to drive more index testing. The question that I had for you, Dr. Beatrice, was really thinking about what we've heard about negative outcomes related to index testing and a lot of concern from civil society. We know that implementing partners are now doing assessments of their sites to ensure we're meeting minimum standards. And I'd just like to hear from your perspective whether or not you've seen or experienced or heard about any negative outcomes and what your efforts have been to kind of ensure that there aren't any. That's one question. And then the second question I had, if you're able, any successes in reaching secondary partners and not primary partners, so getting beyond just the wives or primary partners of index clients. Thank you for the presentation. Over to you.
Okay. I think I'll start with the second one, our efforts in reaching the secondary partners. So as we have said in the presentation, our index testing approach targets elicitation ratio of one newly identified positive to give contacts, either 2 or 3 could be sexual partners, could be biological children. So throughout our mentorship, our technical support we are providing at the facilities, that has been like a cornerstone to ensure that we are reaching those secondary partners and not only the primary partners of these TX new or HTS4s in the supported facilities. We are not yet there. Sometimes we reach that 1 by 2 in some of the regions, in some of the quarters. But on average, as I've said, we are 1 by 1.7 for this Q3, and it's an area which we need to work more, index testing is not easy, it's not a one-time thing. You have to do repeated consultation and counseling to these newly positive to ensure that they provide those information. So I would say it's a work in progress. On negative impacts or negative outcome for the index test, on the index testing implementation, and for our setting, not really. Of course, we have one of examples, maybe because most of the time it's the provider referral, the mode of the referral use is provider referral. So the provider can be calling a contact, and then the contact will like, where do you get my number and all that. So they use their clinical skills to ensure these contacts accept these services, but we don't have a significant impact which have affected our index implementation. No. Thank you.
Dr. Beatrice, thank you so much for your fantastic presentation, which has resulted in numerous excellent questions being asked and great conversation and responses from you. I do want to we're wrapping up the session now. There is a brief survey for everyone to be able to do. I think Monica will change the screen now to put that information up. We're so thrilled that 135 people have joined this session. Hopefully you all found it informative and got a lot out of this. Moving forward, as always, please remember that the OHA HTS team is always available to answer any questions at htsteam@usaid.gov. And I'm not sure, Mike, if there will be a way for participants to continue to ask Dr. Beatrice questions after this session, or if her contact information will be available.
Hi, Liz. Thank you. Yes, the contact information will be available on the on-air platform. You can also search for attendees and panelists. Their information, you can reach out to them directly. So the platform does offer that ability for you to reach out. And all presentations will also be available tomorrow if you would like to have a copy of the presentation. So please do look around the platform. You'll see that there is a lot of information and different functions available to connect with other participants and panelists.
Great. Thank you, Mike. Thank you to everyone for joining. Please fill out the quick 3-question survey. It should only take a few seconds to do. And it's been great having you for this session today. Hope you enjoy the rest of the meeting.
Okay. Thank you, everyone. Have a great rest of the day, and we look forward to engaging with you on other sessions. And thanks to the panelists. Thank you, Liz, Marina, Beatrice. It was wonderful. Thank you so much. And to our team supporting us and making sure this is a seamless presentation. Thanks, everyone.
Thank you.
Thank you, everyone.